So this case is a 70 years male and diagnosis is a stable angina. So today's target lesion is a proximal LVD CTO. And so coronary risk factor is hypertension and hyperlipidemia and past smoking. So this case was already treated RCA and circumflex at the end of the last year and so this year. And so JCT score is a 2 and the syntax score is a 15.5. So EGFR is around 60 and LVEF is about 70%, so that cardiac function is so good. And so the case is that there is some collateral. So this is can you see the angiogram? So there is septal to septal, and so this is from RV branch to the already distal. And this is major collateral from the conus branch to the distal LAD. And CTO distal target is LAD and diagonal bifurcation. And this is cardiac CT. So cardiac CT shows CTO length is around 12 millimeter. And the major problem of this case is blunt type of the CTO entry. And so at the entry, so there is some calcification. And this is also cardiac CT, and that's all. So please state, Dr. Katoh.
So we prepared the relatively simple LED CTO. So from the CT angiogram, we guess the occluded vessel is relatively straight. But difficult to see the CTO entry. But collateral from separated conus branch is revealed the CTO exit. It's very clear. So to enter the CTO, we will try the IBUS guided wiring. And also to cross this CTO, we will show the IBUS guided wiring. So the first, we will try the, to enter the CTO entry. So I will show the IBUS image. We will pull back from the septal branch. So this patient has a very unusual anatomy of LAD. So just like a double LAD, the patient has a very big septal branch. Also the main branch of LAD is completely occluded. So I pull back the IBUS from the septal branch.
Now we see the IBUS.
Oh, okay. So you can see the occluded LAD at 10 o'clock here. But from the diagnostic angiogram, we expected the CTO entry is a little bit more proximal, but not true. The IBUS revealed the true CTO entry was a little bit distal to the first band of the LAD.
So there seems to be some calcium in the wall.
Yeah.
Of the proximal cap.
Yes, but we are lucky. The true entry of the occlusion is no calcium. So we can see the calcium that's behind the true entry. So probably the wire can get in the CTO, I hope. So
For visualization, you have a caravel in the conus branch, to reduce contrast.
Yeah. Yes. And also the stabilize the catheter to the ostium of the separated conus branch is very difficult. So the catheter is very unstable. So I put the wire into the main branch of the RCA, and then I put the guide wire into the separated conus branch. Then I put the caravel to the conus branch. the contralateral injection was done through this caliber catheter. We made a marking, so you can see the two markers. Can you see the three markers? So the mirror of this ibis is the proximal two between the proximal two markers. Then the true entry of the LED is around there. So I will try to puncture the CTO entry. Of course, we can see clearly the entry from the angio. So we need the IBIS guide to get in the CTO. So to IBIS guided wiring, we prepared a special system. I use the one guide wire and IBIS catheter on that guide wire. Also the Sasuke is on the same wire. We call it
that is something unusual.
Strip stream technique. Anyway, so now the tip of the cassette, the Sasuke is lead to the LED. So I will move the IBIS to show the entry. Yeah, for this technique, we need the thermo IBIS, the double R system. So this system, this IBIS cassette has a very short molar tip. So we can use this cassette for this technique. So
You think this working projection is okay in the right anterior, please?
yeah.
Or you could go to the earlier where you might still see some,
Yeah.
at least the side branch angulation could be seen, because here we are seeing them parallel.
Yeah, this patient has a transverse position of his heart. So we need a very deep caudal view to see the ostium, or to see the proximal part of the LED. So the deep aerial view is impossible. So we can't see clearly the ostium of the CTO. But now we have IBIS. So IBIS is very useful in this situation. So I will show this.
What is the wire that you want to use for the first puncture attempt?
Yeah, the Gaia next 2. So I will do the tip injection. This view. Okay. So in the beginning, I explained the CTO vessel is relatively straight. That's not true. I expected the long CTO entry. So this LED is a little bit the bend at the bifurcation. So we have to turn to the distal here, and also we need RA view. So this view is just from the tangential direction to the myocardium. So this view is very useful to recognize the gap between the wire tip and the distal tube. So, okay.
In the meantime, I can answer a question from the audience that was regarding the IBIS. This is a mechanical probe, the Terumo probe, as compared to a Volcano. And the Volcano has a longer monorail part, so you couldn't use it in this situation. You need a very short monorail. I think even the Boston has a short monorail to get this double lumen catheter right close to the tip.
So
Now the problem is you have a bend on the Gaia, so the Gaia is not as controllable as you would like, certainly.
Yeah, this is the Gaia next, so more controllable than the Gaia.
But you have two bends.
Yeah.
Actually, after getting into the CTO
right.
body, we would have loved that there was no curve. It was a normal curve only, so that you can walk more straight.
Yeah, but in this situation to get in CTO occlusion, the CTO entry, there is a space. So anyway, we need second curve. Okay, just a second. Okay, just okay.
So that extra bend which helped us to get into the CTO body will be a pain
no.
for us now as we walk
Yeah.
through the
Second
CTO body.
bend is helpful to get in CTO entry, but not good to
After that, it
control
is a
the
pain.
wire after that. So
Yeah.
yes, of course.
But
one
the
of the
problem
options we
is
can
now
change
you
to the
cannot
microcaster.
easily change for a microcatheter.
Yeah,
you have to
yeah.
remove everything,
Yeah.
including IVUS, so
And
it's
I think
very delicate.
And at this point, I think probably IVUS requirement is not so much. So I think if one can control it very well, then
okay, this two. Okay, so this position is better than before. So I will control this wire.ちらっと。外れたかな。上か下かどっちか。
Even from the CT, the distal cap looked very blunt also. So
Yeah.
difficult to
the
get.
entry
but
may be
we don't
problem.
know.
Only a
The-
small streak was getting up the bifurcation.
Yeah.
Are you there already?
No.
Just
It's
short.
it's the whole channel. Okay.
But you could switch now and get the Suzuki on this one and do a parallel wiring?
Yeah. Okay. So
Just short.
okay, I will change the system. We don't need the IVUS anymore. So
So you have a 7 French system or an 8?
8 French. So we usually use the 8 French
French.
for the IVUS guide. So
Still,
yes,
you
the
cannot get a balloon inside, trapping?
Yeah. No.
But usually we can, but this time is the Sasuke and IVUS in the 8 French guiding. Even though the 8 French guiding, we cannot use the trapper balloon for this situation. So the Dr. Kato using the extension guide wire to remove the Sasuke. He has Sasuke.
Will you use the Suzuki?
Yes, Sasuke. Yes.
Okay. So this is set up for dual wiring or
Yes,
parallel
yes,
wiring
yes.
over the dual loom
Yes.
catheter.
I will. Okay. So I will try the
And it's very
double wire
important
technique.
not to inject contrast. Yeah.
Okay. So
Many
I will try
many
the double wire
people
technique.
who are not experienced,
So
they inject antegradely and contrast.
So there is big
He
no
is
for
not.
that cigarette at this point actually.
2じゃないわ。
Whatever you want to see,
Guy
inject
next
to
one.
the microcatheter
Yeah.
in the artery branch.
So your second wire is Gaia next one.
Yes, guy next one. So if failed the parallel wire technique, I will switch to the IVUS guided wiring again. So I will try the
Don't you think you can pass the suo through the collaterals?
you mean a retrograde approach?
Yeah.
Yeah. Yeah, this patient has many the channels connecting to the radio, so we can do the retrograde approach. But now our strategy, especially in Toyohashi, we have focus on antegrade approach again. So the already retrograde approach is widely penetrated. So now it's very popular. So that as an inventor of the retrograde approach, I'm worrying that the use of the retrograde approach is now 40% in European and Japanese registry. I think it's too much. So for the next step, we need the improved antegrade approach for further the progress in this area. So now we are focused on antegrade approach again. So I will try. Of course, the IBIS guided wiring is failed. I will switch to the retrograde approach, of course. Okay, 最後の撮影もう一回見せて。
So this part is very clear. Even the most experienced persons in the world, they still will give an adequate trial for the integrate. Even though this retrograde appears to be sizable, and I think for those who are in the business of doing retrograde, it's probably not one of the difficult ones, and so should rather walk in or float in through this. And this can be followed with a softer catheter, but I think the operator still wants everything to be done integrately, and even if the integrate nipple was not seen so well, it was good to take the help of the IVUS and puncture with a wire with slightly higher tip load, but now shifting to a wire with a lesser tip load.
So in aerial view, we can see the distal bifurcation very clearly. But the important things in the right aerial view to confirm the wire position, I mean in the myocardium side or the epicardial side.
Yeah. So it's the good view from the aerial caudal view to recognize the vertical gap between the wire tip and the distal lumen. But now we have to they move the wire tip. We need the horizontal gap. We have to see. So we are now seeing the aerial view. Okay, check please. Okay.
Now his wire in aeriocranial view is located at the top of the bifurcation. So maybe wire go to the diagonal, right?
Yeah.
So we can check now.
No. It's a 4-channel. Yeah, 4-channel or perforation. Okay. No. So probably I dilated, expanded 4-channel or subintimal space. So the wire can go anywhere. So in this situation, we need the IBIS guide. So I will put the IBIS into the LED.
The first wire seems to be directed towards the diagonal. Is it correct?
Yes. Yeah. Diagonal. Maybe
so you
the
could
first
put
wire
the
is
IBIS
in
on this first wire?
First wire is in the 4th channel in diagonal. So
Diagonal.
diagonal.
You will take the IVUS on this wire which is in the diagonal.
I will check the IBIS. I checked using the first wire. So I don't know the IBIS can get in the CTO easily. どっちの道かなこれがパスワイヤー
So IVUS guided re-entry or wiring within the occlusion is even more difficult than IVUS guided puncturing of the
Yes,
cap.
but depend on the situation. If the subintimal space is become very big, it's very difficult, almost impossible using the mechanical wire. So also the difficult using the stingray balloon. So it's a very difficult situation. Now the IVUS is coming. Okay, so this after getting the occlusion, yeah, so already we're in subintimate. So we have to change the wire course at the very proximal part. So this is the
You repuncture proximal.
yeah. This is the one of the advantage of the IVUS guided body. So
Will you try again the technique with the Sasuke on the wire, on the
no,
same wire?
no, the already the IVUS in the CTO body. So I'm using これどうするかトラップはした方がいいかな。まあいけるやろ。で using a Corsair.
So already we can get the proximal cap with IVUS guidance. So actually the orifice itself is a true lumen, but the wire is very easy to, already gone to the subintimal space.
Gaia next one.
Very proximal to the CTO body.
So we have to go to the.
So with which wire do you want to work now?
Gaia next one because we have already. So I will try the Gaia next one.
Okay.
If possible, I will step up. We have to go to the 7 o'clock on the IVUS. So of course we need some second bend because the proximal part has just some space. So okay. I need a little bit small scanned curve. So
So we often use a conquest or confianza type wire for this penetration.
yeah, it's the Conquest type. The guide wire has a very ball tip chip. So it means this wire they easily strip to the distal. So we need a very sharp the guide wire to get into the tissue. So for that purpose, the Gaia Next is better than
Conventional wire.
Yeah.
How about the Conquest Pro 28?
No, it's the same. It's a Conquest itself. The chip load is very hard, but the issue is the chip of the wire. So Dr. Katoh already mentioned is the chip of the wire had is a little bit big and slippery. So even though the chip load is very high, Conquest 820 very easy to go to the subintimal space in this situation. So getting the tish, getting the true lumen is very important. That's why he need to the sharp wire chip. So Gaia next one, the shape of the chip is more sharp compared with the conventional guide wire. So now is the second wire is getting is the true lumen. You can see the second wire is a around 6 o'clock. So his second wire is now getting the true lumen.
I hope so.
Yes. Yes. ちょっと押しますよ。ちょっと押します。はいはい。Now maybe you can see the second wire is 7 o'clock inside the looks inside the true lumen.
Yeah, we see.
Okay. So I will bring the Corsair deeply to get more support. Okay, it's a very dedicated procedure, so take time. So now is tip of the corsair is in the true lumen. で、アイバスちょっともうちょっと引いて。いける？
はい、これですね。今。Now is the second wire, the 6 octave still inside in the intimal. So, now,
So,
So you advance the Corsair behind already, and then
Yeah,
you will
yeah.
switch wires, or you will try with this one?
now, yeah, it's one of choice. Okay, go to this one. This one.
アイバス。ちょっと
ちょっとだけ。
あれを見せてもらっていいですか。ちょっと一回システムが。
Okay, already out. So I will change the wire. This wire is too sharp, so I will advance the corsair into the this plug. So okay. So XTR. I will switch to the XTR. I will show the position of the corsair. Can you see?
Yeah.
So we already confirmed the chip of the corsair inside in the intima. So now he will use XTR to
But
negotiate
the second
channel.
wire advanced rather deep now into the first wire, I mean, with the knuckle.
Yeah.
Has a high risk of dissecting this diagonal.
Yeah, it's a problem. But if we can get the true lumen at the bifurcation, probably the dissection created by the first wire is not so big issue. So anyway, we put the stent around there.
So you are now using a very soft taper tip wire.
Yes.
But still, I think the distal cap could be a problem because there's a lot of calcium.
Yeah, but from the CTO findings, there is no calcium disturbing the wire control at the distal end of the CTO. So I hope this floppy wire can negotiate the vessel. So
エリッポですね。まあ一応でも中ですね。
違う。
で上がってきちゃうんですよね。
いやこっちでこれ横に行ってしまう。On the iris, the tip of the corsair is in the interplug. So I will change to the Gaia next one again. I need better controllability. So okay.
So you're within the vessel, but you're stuck in the plug.
Yeah, stuck in the plug. So it's good. So it was difficult to control the XTR. So I switch to the next one.
So do you remove the secondary shape or you add a secondary shape?
No, it's I just changed
did you do with the wire?
the angle of the first wire, the first curve. So because we need change the route just after the tip of the corsair.
So,
I
you,
need,
so you're shaping it the same way as it was done the first time.
Yeah, I did the reshape.
Same shape.
Okay. So, did it difficult to control
Are you sure
this
that
wire?
it has penetrated? No.
No, it's just tracking the vessel.
あ今の
So
中です
now is
Yeah.
the wire tip is inside the vessel.
中だけでです中だけ
ちょっとディスタル
いってますあ今これで見えないんだよな
The problem
でも
is
今多分中にいますよね今中ですよね今中に
problem is
あ出ちゃう
we can't see the distal part. Okay, injection. Because of the calcium. Yeah. Okay. So I will use the angle guide at this moment. ちょっと出たかな。はい、じゃあもう一回。
はい
Okay.
Very close,
Yeah,
but
it's very close. じゃあこれちょっとこっちクラニアル
in the other projection?
Yes, cranial. Dr. Berman, the Canon Medical asked me to explain about the DTS system in the X-ray system. So maybe you can see the DTS, the simulation image.
Yes, we see.
Yeah. So the fluoroscopy time is now is minute. I can see
boss is almost 15 minutes
15 minutes.
but front
No, 23
yeah,
minutes.
23 minutes in the front line
Yeah,
the lateral is 28 so
28.
the totally the flow time is around 50
50. Okay.
but our radiation dose is 1.8 gray
1.8 gray. But in the DTS, its skin dose is very low. So you can see the blue indication. So it means around there, the max dose is 861 milligray. So 0.8 to 0.9 gray. So in Japan, we can use this system routinely. So this system is useful to avoid a hot spot. Recently, this system is very precise. So in the past, this system is not so precise. So the indication of this system is not reliable, but now it's very reliable. Is that okay? So we have no time. Okay. I will show the last
probably we'll have
diagram to show the collateral channel. Okay.
Yes.
Now it's not clear, but the most distal tail branch connected to the diagonal branch. So I will use this channel. So
The channel we don't see, you will take.
yeah, maybe we create the hematome to the vessel. Maybe
Okay.
yeah.
Okay, we are pretty sure that you will finish this case successfully with the retrograde approach using one of the channels.
Okay.
And I think thank you very much for transmitting this interesting case with a new aspect of dual lumen catheter on top of the IVUS.
Yeah, same bar.
Thank
Same
you
bar.
very much.
Thank you.